Welcome to our brown bag series. We're pleased to open up this particular brown bag to our broader community. And today, Lynn Panton is going to be giving the presentation. Lynn is a professor in the Department of Nutrition, Food, and Exercise Sciences. And she received her undergraduate BS from Emory and her MS, ESS, and PhD from our neighbor down the hall, so to speak, University of Florida. She's a fellow of the American College of Sports Medicine. Her research interests are primarily in the topics of strength training, the effects on physiological measurements of strength, blood pressure, cholesterol, body composition, and functional outcomes of healthy elderly adults and chronically diseased populations. Her recent research is focused on the effects of strength training in women breast cancer survivors. Today, her topic is strength training, the fountain of youth, ?
Great. Thank you all for being here. Neil, thank you, and the Institute for inviting me to come and give a talk this afternoon. What I'm going to try and do is keep the talk to about 45 minutes, so that if y'all have any questions, I will be happy to answer those. So what I'm going to do today is talk a little bit about the research on human subjects that we have been doing over the last 25 years or so. I won't tell you all about those, but choose a few of the studies that we have done. So I'm hoping I am preaching to the choir, and that all of you out there are getting some types of physical activity. The recommendations for aerobic activity is that everyone should do at least 30 minutes of physical activity at a moderate intensity on most days of the week. So that physical activity is activities such as walking, cycling, and swimming. So hopefully all of you are doing something like that. But I also hope that you're also incorporating a strength training program. Aerobic exercise such as that walking and swimming and cycling is great as far as preventing and helping to attenuate the effects of cardiovascular disease, type 2 diabetes, and decrements in cognitive function. But that aerobic type activity really doesn't do a lot as far as promoting your lean body mass, such as your muscle mass and bone density. So that strength training is so important in helping us to increase that strength and lean mass. I don't know if you all know, my students are always surprised when I ask them, do you all know when your muscle mass starts to decrease? And when muscle mass decreases, we also get a decrease in our bone density. Does anybody know? So if you aren't doing anything to strength train or to overload those muscles start to decrease, that muscle mass starts to decrease in your late 20s and early 30s. Well, a lot of us have a great deal of reserve, men so more than women. But it becomes more problematic as we get older, and especially for women who, once we hit menopause and we lose our estrogen, that loss in bone density really starts to accelerate. And it's not uncommon for us to have 1 to 2% of our bone loss each year. Men lose bone too, but they have a greater reserve. But we do see a lot of men in their late 60s, early 70s starting to have problems with bone loss. So, so I hope at least I can get you thinking about doing some strength training, especially with the data that I'm going to show you here. So I'm going to let you guys think or choose whether you believe that strength training is the fountain of youth. So let me ask you a question. What do you all think of when I ask you to think of somebody in their late 70s, 80s, early 90s? What picture comes to your mind? Oh. So I don't know, hopefully all you can see the three pictures here. But we have a woman at the lower end here, or at the bottom of the screen, that's kind of hunched over. She's frail, low muscle mass, and chances are she has osteoporosis. She's hunched over, and literally she's walking on a slippery slope. Can you all see okay? On a slippery slope there. So if she falls and gets hurt, breaks something, is hospitalized, she could likely end up like the two individuals above her that are maybe confined to a wheelchair or bedridden. So a lot of times, you know, when we think about these older individuals, we think of that frail person who has that low lean body mass, that low muscle mass, that low bone density. So I love this cartoon here. You know, cartoons depict what's going on in society. And here's this fella that's coming to the wizard, and he asks the wizard, "Do you have anything to stop the aging process?" And the wizard goes, "Yeah, sure. What kind of disease would you like?" And I think a lot of us believe that as we get older, we're going to develop some type of chronic disease. If I was the wizard, I would have stuck the person on an exercise program. If you all get a chance to hear this TED Talk, this is by Charles Eugister. It's a little long, but it's really good, and he talks about aging and physical activity. And I think it's true for a lot of us that we think that as we get older, we're going to get some type of disease. But aging can be perfectly healthy if we look after ourselves, if we exercise and eat in moderation. So Neil shows this slide to kind of introduce the Institute of Successful Longevity, and I'm sure all of you have seen it. And I've kind of doctored a little bit, and I put the gym under it. So do I totally believe that we can bring people into the gym and spit out a younger version? No, we can't erase the gray hair, the wrinkles. But when you listen to our participants talk after they have been exercising with us for weeks or months, they do seem like a younger version of themselves. They tell us about having more energy, being able to do things more independently, picking up their grandkids, opening jars of pickles without having to ask their significant others or their younger children to help them. So, yeah, I believe that exercise can at least help attenuate and reverse some of that aging process. So again, I'm going to let you all decide whether this is the fountain of youth, but I have some bias there. Of course, take a look at this fella. He is 78. You cover up his head, and that's a body a lot of younger individuals would love to have. I'm not sure that's all natural. I think he's had a lot of help on the way. But right now, we don't have a legal drug that actually puts on muscle mass for us. But I know we have some faculty in the department looking at some different mechanisms, and maybe one day there may be that drug that can help maintain our muscle mass. But here's some pictures of individuals that have exercised most of their lives and have done it naturally without taking hormones or other things. I just kind of want to go through this just real quickly. This gentleman right here, you can see very muscular, lots of very vascular. And I don't know if you can see his age, but he's 79 years of age. This gentleman up here looks like Johnny Carson to me. But again, his strength is amazing. A lot of us, our young people, can't balance their weight on their hands like this. And I'm sure he was probably a gymnast when he was younger. But this is my favorite picture down here. This woman here deadlifting. She's a master athlete. She holds the world record in both the bench and the deadlift. And I'm not sure if this is a 45-pound bar or a 65-pound bar, but she's deadlifting over 130 or 135 pounds or greater. But I love the pictures, the faces of these fellas watching her. And then this last lady right here, she didn't exercise her whole life. I found her story probably, I think it was in the late 90s, no, early 90s or late 80s, out of the Miami Herald in the Parade magazine. And it had a number of pictures of her. And it told her story. And she was 68 years old. And she had lost her husband. And she was trying to go grocery shopping. And this was before Publixes were all over the place. And she wanted to, I don't know if it was dog food or kitty litter, but she could not pick up this bag and put it into her shopping cart. So she had to go around the store looking for somebody to help her. She found somebody, they helped her, she went through the checkout, but then she had to find somebody else to help her get it into her cart. When she got home, she had to wait on her kids to get there to be able to get the bag out. And she was like, no, I am not going to be dependent on somebody to help me do my grocery shopping. So she started going to the gym at 68. And 4 years later, at 72, she is competing in her first bodybuilding competition. So just an amazing story. And she was on all sorts of news channels in the 80s. I think Katie Couric, or 90s, I guess. Katie Couric interviewed her. And she really brought to life a lot of weight training for women, because there wasn't a lot of strength training being done at that time. Just want to show you a couple pictures of people that I've worked with. So when I hear individuals telling me, well, I'm just too old, it's too late, I'm too ill, it's past my time, I'm not going to get the benefits. That's totally untrue. The body is amazing, and the muscles are amazing as far as their ability to adapt to an overload. So research has shown that people in their 90s and even into the hundreds still remain the capability of getting stronger and for the muscles to increase in size and to hypertrophy. So it's not lost. And that ability to adapt it is there. So it's never too late to start a resistance training or strength training program or to exercise. So just a few of the participants I've had early on when we just looked at healthy individuals, and they have made great adaptations as far as building up their lean mass and their muscular strength. So I want to highlight a few of the studies that we have done. And most of our interventions are pretty similar. We tweak a little bit here and there. So I just want to show you an overview. I won't really go into a lot of detail about the training that we do. But most of our studies are from 12 weeks to 6 months in duration. All of the studies, we have people come in and exercise twice a week. And we perform 1 to 3 sets. So we try to get the individuals to exercise between 8 and 12 repetitions of that exercise. Once they fatigue, that's the end of that first set. And we do 3 sets then. We try to do the same exercise prescription that is scientifically based and is recommended by the exercise professional and our governing body. So we go in through that 8 to 12 reps, and the research has found that range is the best for strength development and for hypertrophy and increasing that lean muscle mass. If you're doing less than 8 reps, that weight may be too heavy if you're fatiguing. And then once you get over 12, you're not really overloading that muscle with a high enough stimulus. So we like to keep that weight range between 8 to 12. And the percentage, we base our percentages on this, what we call the 1 repetition max. So that's the maximum amount of weight that you can lift one time. And we can take a percentage of that. And usually these percents correspond very well to the number of reps you can do to fatigue. So if you're fatiguing in 12 reps, you're probably exercising very close to 60% of your 1 RM. And if you're fatiguing in 8 reps, you're probably exercising pretty close to 85% of your 1 RM. So these are the exercises that we do. We do about 4 to 6 for the lower body, and then 6 to 8 for the upper body. So there's not as many muscle groups in the lower body, they're just bigger. So we try to do something for your quads, the front of the legs, the back of the legs, your hamstrings, your calves, and then of course your bottom, your glutes. And then hit those major muscle groups in the upper body, your chest, your biceps, triceps, abdominals, lower back, upper back, shoulder area. So those are the exercises that we use in all of our studies. So the first study I want to talk to you about is a study that we did when I was at East Tennessee State University in Tennessee in Johnson City. And it was work with pulmonary patients. We had a lot of pulmonary patients, as you can imagine, in the northeast corner of Tennessee. This is a very frail population, and they have a lot of comorbidities. Their lung function is compromised, and most of our patients were emphysema patients, and this was caused by smoking. The one thing with the lungs is that once you destroy one of those alveoli, there's no getting it back. Heart is a little bit better. If we do damage to our heart with exercise training and other things, we can help the vessels collateralize. We can get collateralization and better blood flow. But once the lungs are damaged, there's really no improving that function. So these individuals are very frail, they're very disabled, they're very limited by their breathing. Then they take steroids, which also causes more problems with their skeletal muscle and bone density. So again, a very frail population. The pulmonary rehab program in Tennessee did not have a lot of strength training machines or modalities for these individuals. So they did a lot more cardiovascular type exercises. So we went in there and we recruited patients to come and exercise with us twice a week just to do resistance training. So we didn't ask them to stop their cardiac training or their cardiovascular training program, just to add 2 days a week of resistance training. The intensity was very low. They were very weak to start with, but the adaptations that these individuals made were amazing. They seem to respond better to strength training than they do aerobic training because it doesn't tax their lungs as much. So we had great adherence and compliance to our exercise program, and they made amazing benefits. So we saw a 30% increase in upper body strength and lower body strength. We found increases in lean mass and decreases in body fat. And then what's really important, we found improvements in physical function. So their ability to stand up, their ability to climb stairs, their ability to pick up books and putting them in the shelf, folding. So all of their activities of daily living improved. I just want to show you data on the 12-minute walk. And we didn't really think we would see improvements in the 12-minute walk, because usually you say, well, if you want to improve walking ability, you need to walk. But if you are weak and you're frail, you are going to be limited in your ability to move. So we're finding that people that are very frail may do better starting a resistance training or strength training program first, and then can move to more of an aerobic-based program when they do become stronger. But these individuals were doing aerobic training, and So this is our control group here, and it's not a real control group because they're doing some walking and cycling and armagometry type exercises. But here's the group that we added the weights to. And after the strength training program, they made a 200-meter increase in their distance that they walked. But what was really cool is that they improved the distance that they walked without taxing their cardiovascular system. So their heart rate, they walked further, but their heart rate wasn't higher. And then these two measures, the rating of perceived exertion and the rating of perceived dyspnea. So RPE is a psychological, it's a no right or wrong answer, but it's a perception how you feel the activity to be. So they walked farther, but didn't feel that their activity was any harder. And it didn't bother their breathing. They didn't have an increase in that perception of breathlessness. So now we got these group of people to do more activity without it exerting more effort or problems with their lungs and the heart. So, I mean, ideally, we would love that, you know, for all of their activities of daily living, make it easier for them and that perception and the stress of doing those activities. One of the best results, and you don't see these results, we don't publish these stories behind the research, but I mean, there's tons of stories, but this one especially. So one of the gentlemen that was in the study, I mean, he was in tears. And he came up and said, you know, you've changed my life. This man lived in a very rural community in Roan Mountain, and his mailbox was a quarter of a mile from the house. So as he started training with us, he would have to wait for his son to come home to bring him his mail. So during the study, he was actually able to walk out to his mailbox, get his mail, and be able to walk the quarter of a mile back to his house with the mail. And then near the end of the study, he actually got a part-time job working at a local hotel in his area as a receptionist. So, I mean, just amazing results as far as getting people more independent, improving their activities of daily living, and ultimately improving that quality of life. Another study, another sample of population that we've worked with that are very disabled, and you'll see that with some of the data that I'll present, are women with fibromyalgia, and men can get fibromyalgia as well. And for those of you that may not know what this disease is, it's these women and men suffer from a lot of pain, fatigue, and there's a lot of disability with this disease. A lot of individuals can't work, or they miss a lot of days of work because of the pain. Women and men present with pain throughout the body, and to be diagnosed with this, and there's a number of criteria, but usually you have to have pain in 3 of the 4 quadrants of the body. And then you have these tender points, and you can see the tender points that are on this schematic. And to be diagnosed with fibromyalgia, you have to test positive for 11 of the 18 tender points. You have to have pain for at least 3 months. And then there's a whole host of other things, such as fatigue and difficulty sleeping, and so lots of different things associated with this. Well, we worked with, I don't know if anybody recognizes Dr. McMillan. He is one of the rheumatologists that work up in Thomasville, just a wonderful man to work with. So he evaluated our women and helped us to recruit those individuals. So we've done a number of studies with them, just kind of getting some baseline information on their function. Because at that time, when we were doing these studies, not a lot of objective measures of function. Had a lot of subjective measures with questions like, can you do this, can you do this? But those subjective measures, if you don't do a task, then how do you know you can do it? Or if you remember that you used to be able to do it, do you really know now whether you can do it or not? So a lot of the subjective measures are not really accurate, like the objective measures of function. So in our lab, we have this testing environment called the Continuous Scale Physical Functional Performance Test. And we can objectively measure what individuals can do. So there is 10 items on this test. They go from easy effort to more difficult effort. So it's some pictures here is picking scarves up off the floor, transferring clothes from a washer to a dryer, from the dryer to a basket and putting it on the table, taking groceries and walking with the groceries up and down steps, going out into the hallway, transferring pots. I think we have a pot carry test, getting up and down from the floor, walking, and then doing some stair climbing. So we could quantify the performance based on the time it takes to do different activities, how far a person moves, and how much weight can they carry during the tasks. So what we can get is a score for total function, and then we can isolate different areas. So we can get lower body function or strength, upper body flexibility, a balance and coordination measure, and an endurance measure. So we wanted to know, how limited are women with fibromyalgia, and compare them to age-matched healthy adults that were also that were healthy and not diagnosed with fibromyalgia. And then we were also working with an older group of women. So we wanted to kind of compare how these three groups of women were with each other. So of course, our older women are going to be significantly older than our women, fibromyalgia women, and our healthy age and weight match control. And you can see we did a good job of recruiting the women for that. And then, of course, we wanted a match for body weight, because the heavier you are, the more difficulty, too, we know, with doing activities of daily living. So our women were heavy. They were on the obese side. And our older women were just overweight. So what we see here in this highlighted green is that the healthy age match women are much higher in these measures than both our women with fibromyalgia and our older women, who are 25 years older than our women with the fibromyalgia. So we did a strength measure relative to body weight to kind of equal that out for comparison. So we see very similar between the older woman and the women with fibromyalgia. And then look at the scores for function. So the kind of the threshold for living independently without changing your routine activities of daily living is usually around 57. So we're seeing like 54 to 57. So after 57, most of our independent community living individuals are scoring above that. People that are in assisted care are usually scoring around 40, upper 40s, and then of course lower than in the 30s for more dependent care. So our women with the fibromyalgia, when you talk to them, they've already made adjustments in their activities of daily living. In the kitchen, they have moved pots up so that they don't have to bend down, because they have lost a lot of lower body strength, and they don't have that ability to stand up. They don't make their beds. They have significant others helping, or other individuals helping with the laundry, helping with cooking. So they report having a lot of problems with their ADLs. So if you think about it, these poor women who are 25 years younger than these older women, the future doesn't look real good for them as far as them living independently with this disease. And just like with emphysema, we can't cure the fibromyalgia, but what we hope to do is to be able to increase their strength so that they can do their activities of daily living and help cope with the disease that they have. So we did a strength training program, just like the program we did with our emphysema patients. It was a very low intensity because one of the things with working with fibromyalgia, they may feel good, but if you push them too hard, they can have an active flare up and they can be in bed for the next week or so. So we were very conservative with them. We did a very low intensity. We progressed very slowly. And we had some, you can see we had some amazing results. They significantly improved their strength and their function. And this is our control group that didn't exercise over the 12 weeks. And all of them, with the endurance a little bit higher, but a lot of their values were below that 57 unit threshold. These individuals, of course, that was their pre-test, but did the strength training program. And we saw then significant increases with their function in upper body strength and lower body strength. And that's what we were hoping for. We did get some improvements in endurance and in their total function. And all of these values are over that 57 unit threshold. So they were really funny. So afterwards, they did, you hear the stories that, oh my gosh, I feel so much better. I'm stronger. I'm able to do things. But when we did the functionality test, they would say, you better not tell my husband I can do this. We were like, no, everything's confidential here. We're not going to tell anybody your results. But it was really nice to see the improvements that they had. The other thing too is this rating of perceived exertion again. So these ladies are moving more weight, they're going faster, and they're going greater distance without that perception of effort being higher. And in this case, that perception of effort was even lower. And then the last group of individuals I want to talk to you about are breast cancer survivors. And we've done a number of studies with women that have undergone breast cancer treatment and are successfully in remission. We know that chemotherapy, radiation, hormonal suppressant therapy not only helps kill the cancer cells, but it also can destroy and hurt the healthy cells. There's a lot of, now that women, the medication is so good that we're seeing more and more women survivors, which is great news, but we're also seeing a number of side effects. And some of those side effects are reduction in lean mass, increases in body fat, decreases in bone density. So again, exercise, very important for our cancer patients to help offset some of the problems they are having with the complications with the treatment and the side effects of that treatment. So we're very interested in the body composition and really in the bone density of our women with breast cancer. So again, we did the same type of thing because we wanted to see what our scale in our laboratory was like and our strength with our women with breast cancer. So we were looking at women breast cancers and non-cancer matched controls. So it's a little bit unfair. This is like a snapshot cross-sectional. So we don't know what the breast cancer survivors were before treatment. So they could be a lot leaner, have less body fat. Maybe they were more active. So we're seeing them after treatment. And now we're comparing them to a healthy group that were not really, well, non-cancer group that is the same body weight as them. So it may look like these results are, oh, it's not so bad, but it's really kind of an unfair comparison. So our women were the same age, and we also matched for menopause status, because one of the things with cancer treatment for breast cancer, a lot of women who undergo chemotherapy and radiation will go into early menopause. We also wanted to try to match for that. So we did, and we did a good job with that. And then, of course, weight. Both groups were overweight, and we wanted them not to be on a structured exercise program, because we know exercise, of course, improves bone density and or at least helps maintain it and improves other kind of things. So we have their steps per day, and that's pretty similar. So when we did measure upper and lower body strength, the women breast cancer were weaker. And again, a little bit of unfair test here, but we looked at our function. And actually our breast cancer survivors had pretty decent function. I have highlighted in the colors in green, and although the non-cancer matched controls were higher, it wasn't statistically significant. However, the colors in green, the values were approaching significant. So they were significant at the 0.08 level. So even though the function isn't as bad as our fibromyalgia women, it's still a little bit lower, although not statistically, than our healthy age match controls. Body comp, again, it looks pretty good. There wasn't a difference in fat mass and lean mass, although we recruited people who were just as heavy and sedentary as our breast cancer. So again, maybe a little unfair comparison here. But bone density in the lumbar area, the femur, were not significantly different. However, when we looked at the upper body, bone density was significantly lower in our breast cancer compared to our healthy control. What do you think? The cancer is in the upper body. And when we talked to the women that came in, a lot of them told us, we asked them, hey, do you do anything for your upper body? And they said no. And a lot of times, well, all the time, when you have surgery, and whether it was a mastectomy or reconstruction surgery, the doctor will say, well, don't lift anything heavy. Don't want you lifting more than 10 pounds, or it may even be lighter than that. But then when these patients have recovered, nobody says, okay, now you got to start lifting and really work at it to build that muscle if you have muscle taken away, and also work on the arms. Do not stay sedentary, because your arms are going to lose bone and muscle if you're not doing anything. So that's really important as far as our ladies that are having surgery, that we need to make sure and are being treated that they start to work on the upper body, because we do see muscle and bone lower. This is a study. Then what we did then was we followed both the cancer patients and the healthy age match or the non-cancer out for 15 months, because we were thinking, well, these cancer patients, do they have the same loss, or is their loss accelerated because of the treatment after they're in remission? So the good news is that the loss isn't accelerated, that they get a normal loss just like the non-cancer match controls, but then our non-cancer match controls are also losing. And what's really sad is that if they have lower bone density, especially in the upper arm, they're losing that they're at a lower threshold. They're not as high as our age matched, and they're still losing. So we see, unfortunately, that both the non-cancer matched and our women breast cancer continue to lose bone over that year time. We also see an increase in fat mass in both our groups. So there's no difference between the two groups of women. They're both losing, and they're both increasing body fat percentage. And then, of course, that ratio of lean to fat mass is also decreasing. So very important for both our cancer and our healthy or non-cancer control groups to exercise, to help maintain lean mass, to help decrease fat mass, and at least to maintain their bone density. So we've done 3 really big interventions with our breast cancer survivors. With the resistance training. And we were really focused on trying to improve this bone density and in these patients. And improving bone density after menopause is really difficult. And we've tried a number of studies, and unfortunately, we haven't been able to increase that bone density, but we have been able to maintain it. And that's also good. So let me just show you. So one of the studies we did, it was a 6-month study, and we worked with one of our nutrition faculty, Dr. Arjanti, with plums. He does a lot of research with prunes, and prunes in animals and some in humans have shown that it may help to improve bone density. So we thought, well, let's combine the strength training with the plum prune, dried prune consumption. Well, we did the 6-month study and we got great increases in strength. The ladies improved strength. They improved physical function on our continuous scale physical functional performance test. But we didn't see changes in our lean mass. So no improvements in muscle, no improvements in fat mass, and no improvements in bone mineral density. We were really disappointed. So we were thinking, well, does the cancer treatment do something? Because there's not a lot of studies that show that breast cancer women improve muscle mass. Definitely strength, but they're not getting big increases or significant increases in the lean mass. So my doctoral student who worked on this is one of the sweetest women you will ever meet. So in the weight room, sometimes you can't be so sweet because a lot of times people don't want to work too hard. So you have to be a little bit, not mean, but a little more encouraging and pushing sometimes with the exercise. So we noticed she didn't hit the level of intensity that we would have liked our participants. So they stayed at really through that 6 months, a little bit near the end of the 6 months, we got a little bit over 60% of their 1 repetition max. And really to see good increases in lean mass, you need to be at a little bit higher threshold. So around that 70% or so. The other thing we noticed with this group of individuals, and there was a lot of research coming out at the time about protein. And as we get older, we get more resistant to the protein that we take in, and we call it anabolic resistance. So we're not as sensitive to given protein load. And they're finding that more and more older adults need greater loads of protein to help with the protein synthesis and increasing lean mass. So we had taken a look at our cross-sectional data, and we looked at women who had a low protein consumption versus higher. And we found that their body compositions were a little bit different. This was just a cross-sectional. So, we found that the low protein versus the high had a higher body fat, not significant lean mass, but we're thinking, well, maybe it's a protein problem that's not driving this increase in lean mass and maybe bone density. So we did another study. This was a 3-month study, so we really didn't get a good look at the bone mineral density, but we wanted to look at lean mass. So we had 2 groups of resistance training, and one took 40 grams, so 20 grams of protein in the morning and 20 in the evening as a supplement. So we were thinking that perhaps the protein would give us a greater increase in strength and an increase in lean mass. Well, it was really cool. Both groups increased strength, of course, and both groups increased lean mass and decreased fat mass. So when we went back and looked at our training intensities, the graduate student who did this study was a taskmaster, and he worked the ladies hard. So they trained at a much higher intensity. So great news is that if we work hard enough, we can improve that lean mass in our breast cancer, and the cancer hasn't done something to their muscle cells that decreases their ability to get bigger and hypertrophy. And they were also able to decrease the fat mass. But the protein didn't seem to work, and we were kind of curious about that. So we looked at some of the dietary logs, and we found, and this is a problem with some of the studies that we have to be careful with, is that this is supposed to be a supplement. So it's in addition to your regular diet. So what we found is that the women, when they took the supplement, felt fuller. So they ate less during the day. So we actually didn't get a 40-gram addition to their diet. We actually only got about 20 milligrams extra. So maybe we didn't get enough protein in there to see greater gains in lean. So that's something that we're going to have to look at in the future. I don't have time to go over this today, but one of our colleagues who left FSU and is now at the University of Alberta in Canada has a great little video teaching the importance of preventing low muscle mass. So if you all download this presentation from the ISL website, you can follow that link, or if you want to email me, I can send that link to you. And then the very last study here, I'll quickly go through this. It was another 6-month study. So we did a review of the literature and looking at changes in bone mineral density with breast cancer. And there's not anything out there that really shows substantial increases in bone mineral density. And really, even with postmenopausal women, it's very difficult with exercise to bring that bone mineral density. You really have to, there's not a lot of studies that show that increase. But some of the studies that do show promise are studies that combine a weight training with impact, where you get hopping and bouncing. So my grad student wanted to look at what we call a functional impact training, which had light weights and a lot of hopping associated with it. And we compared it to a yin yoga, which is more of a passive kind of yoga, not too much body weight where you're on your hands and supporting body weight. So not a lot of strength building activity there. So this has been accepted for publication, and it should be out next year, I think in January. But anyway, again, we didn't see any increases in bone mineral density, but we did see a maintenance over that 6 months. And if you remember from that the follow-up study we did watching the women over a year, we found a 1 to 2% decrease. So it's good news, at least if we can maintain that bone density with these type of group exercises or resistance training. So we found great improvements in strength again, not as much as when you do a resistance training with heavier weights, but we still had improvements in strength and in function. And even the yoga group had some strength increases in the lower body. So if you have women or the women who are coming out from chemotherapy and they don't feel really good and starting well enough to start a resistance training program or impact kind of training, that if they can start with yoga, they may be able to get some improvements in strength. And hopefully, once they feel better, we can get them doing more of those strength building or circuit kind of programs to help further build up their strength. So again, tons of stories with our participants as far as just how much better they feel once they have started strength training and continue it. The activities of daily living, their quality of life, their outgoingness. It's amazing what strength training can do for individuals and that improvement of that quality of life. So finishing up here, I love these cartoons. Here you got Shu, although smoking is the worst thing you can do for yourself. But it says here, with the proper diet and exercise, your body should last a lifetime. And that's my prayer for all of you, that with physical activity and hopefully with that strength training, that your body functions well into your 80s and 90s. If you want more information about strength training, home-based exercise, we received a grant a few years ago, and I got to write this kind of manual with Dr. Pomador and one of my grad students. And this link is from the college's website, the Human Sciences, And if you kind of follow that to the faculty and go to my webpage under teaching resources, this link is here. It's exercise for older adults, and then exercise for older adults for if you're a healthcare provider and you want some ideas. Basically the same book, but written more for the healthcare provider versus for the individual wanting to exercise. This is also on my website, but you can go to NIH, but it's the Goal for Life, written by the National Institute of Aging under the National Institute of Health. The book is both in English and in Spanish, and your tax dollars at work. I don't think they're mailing editions out. You used to be able to get 15 copies of the book, but you can download both of the books in a PDF format if that's something that you're interested in. So slow down. I hope you guys don't slow down and that you stay physically active and exercise. Here's my uncle who's in his 90s now, who still does all his gardening and outdoor work and chopping wood and staying very physically, functionally fit. So I can't put all my students here. I did put my doctoral students. I want to thank all my students, colleagues, and participants, the Institute for funding a grant that Dr. Delp is the PI on, Judy Delp, and we'll be working with her looking at another special population, patients with peripheral vascular disease. So we'll be looking at exercise and stretching with a device that Judy has developed and helping these patients walk. But I know the exercise keeps me young. I do have to credit my students for motivating me to exercise and keeping me young as well. Thank you for having me. I would be happy to answer any questions if you all have any.
Thanks so much, Lynn. And we do have questions in the chat for you.
Let's see. Woo, there's a lot of questions.
Yeah, or some are comments too.
Okay, how much time between? So one of the questions asks how much time between sets. Well, it depends how quickly you want to get in and out and get finished. We usually recommend a minute to 2 minutes of rest time. But what you can do is have no rest and switch up exercise groups. So you do a set of upper body exercise and immediately follow it with a lower body exercise. So you do something for your chest, followed with leg extension. So that shortens the time, and you're giving your upper body a rest while you do an exercise for your lower body. But if you want to talk and socialize, a minute is a good time. For me, my husband just shakes his head, but I weight train when I watch TV. So commercials are long. So what I usually do, we're watching TV, and on the commercials, I do a set of bench, and I do a set of leg extension, and I run back in and watch some more TV, and then run back out on the next commercial. So my husband is like, your rest exercise interval is just way too long. But if that's how you could do it, then, that's, just getting in and overloading that muscle is so important. So I wouldn't worry so much about the time, just getting that exercise done. But if you do what we call a split set kind of thing, you can exercise pretty much back to back and not rest. 1 minute. Bruce answered the question. Yeah, so how do we do it without gym equipment? I wish we could all get into the gym, but a lot of times that's impossible. We've invested in a gym at home. We have a system that has actually worked really well for us, and we've bought a bench. And actually, if you can get your doctor to write a prescription, you can buy a system tax-free. I think they still do that. But you can be creative. My doctoral student with COVID has had to do everything remotely. We can't bring people into the lab to train them. So we have made milk jugs, and you have pint-sized milk jugs or the gallon size, and we have filled them with water, And you can fill them up part way or all the way, depending on how strong you are. And you can have different milk jugs or any jug with the handle. If the milk jug becomes too light, you can fill it with sand. So using things around the house can help. There's actually a YouTube video on how to make ankle weights. So you can use old socks, tube socks, and fill them, get a plastic baggie, fill it with sand, and make ankle weights to do like leg extensions and things like that. If you go and look at either the NIA pamphlet or the book that we've written, we have some exercises and how to do them. So you can use those for reference. And then just be creative with things around your house that's going to give you that resistance and is going to overload that muscle. Yeah, that's one of the things, that our muscles can adapt quicker than our joints and ligaments. And I find now that my knees hurt when I lift weight that's too heavy. So I've had to back off a little bit. So you have to listen to your body. But still, yeah, but sometimes, yeah, trying to adjust, making sure you're doing the correct form can, make sure that you're not stressing the joints. But your joints will get stronger too. Our patients with rheumatoid arthritis, we tell them, strength training is really beneficial in helping to maintain that muscle mass and give that strength and integrity of the joint. So yeah, as we get older, those joints can become sore, but trying to modify, maybe backing off a little bit, but it's still really important to do those weights to keep the health of your joint. Okay. Yeah, lots of different things you can do as far as bands. Um, I mean, bands are great. I prefer, more of the weight. Bands can have a tendency to pull you out of a good range of motion, and we tend to kind of get bad form with them. Not always, but sometimes with the weights, like with the jugs and things like that, you can maintain your form a little bit better with the bands. But if you like the bands, please do those. I'm not, so the question is there advantage to wear a weighted vest while walking? I'm not a real big believer of putting a lot of weight on your body. I know, if you're getting your training to go walk, to hike, and you have a backpack, and yes, you need to do that. You need to be very careful when you start adding weight onto you. That you can change your biomechanics. It can make it, you can become injured. If it's hot out, you can't sweat appropriately and have your sweat evaporate and cool you. So you just need to be careful. There's been some studies using a weighted vest, not outside walking, but helping with doing jumping to get more impact to help with the bone density. And the results have been kind of mixed. They don't really get huge increases in bone density with the weighted vest, but it may help to maintain the bone density. Now weighted vest is not going to increase your strength in your biceps and triceps, so you still got to do some weight, do those resistance training. But sometimes the risk is higher than the benefits when you use those putting weighted things on you when you're walking. I don't believe in walking with ankle weights. I think that's really dangerous, or walking with hand weights, because if you slip and fall, you never know where those weights are going. You can hit yourself with the weight. You don't have that ability to catch yourself, and you're all out of balance. Yeah, I don't really like people walking with stuff on their bodies. I think you can get much better stimulus to the weights doing a seated exercise kind of program.
Okay, thank you so much, Lynn. I think there was
Okay.
just one last question about, is Premier a good choice during this COVID time?
Yeah, I think they're doing all they can to keep you safe. And I think all the gyms, I've heard of in different facilities and in Premier, some of the trainers have gotten sick, but I have not heard anybody getting COVID from the gym. I think they're doing a very good job of cleaning up everything. So it's just your risk, and I don't know. We're not going to the gym, but then my husband has health issues, and so we have to be careful.
All right, thanks so much, Lynn, and thank you, audience. We had as many as 56 people join our brown bag today, so very pleased with that turnout. Thanks again, Lynn. We really appreciated your presentation. I think all of us at this point should start paying a little more attention to strength training if we haven't been already, and wish everybody a good afternoon. Thanks again.
If any of you all have questions that I didn't answer, you're welcome to email me. It's just L, and my last name is Panton, Panton, so like a big pan that weighs a ton. So L Panton at fsu.edu, and I'll be happy to answer any questions that you may have. Thanks everyone.
Again. Bye for now.